afternoon, everyone. We are all excited to welcome you to the first webinar in the Navigating Dementia series. What a fabulous response. We've had over 400 registered for today, which underscores the important work we are all doing to support those of us experiencing neurocognitive challenges. I'm Laura Gillen, a gerontologist, educator, caregiver, and a consultant for this project. Navigating Dementia is an educational series of 5 webinar and 2 in-person conferences about Alzheimer's disease and related dementias, which was developed for a diverse audience of care team members, loved ones, paid caregivers, employees of Maryland Agencies on Aging and Maryland Access Point, and the range of aging services providers. This spring 2022 series is funded by a generous grant from the Maryland Department of Aging, whose vision it is to change the trajectory of aging. The series has been designed and made possible by the efforts of the talented members of the Geriatrics and Gerontology Education and Research Program grant team. GGEAR is a University of Maryland, Baltimore-based program that facilitates the interprofessional education and interdisciplinary research activities in the field of aging in partnership with campus affiliates and agencies and organizations serving Maryland's older adults and their caregivers. Let's take a moment now to recognize our GGEAR grant team members. The graduate assistants contributing to the project's design and development include Shar Bulware, Sabrina Amaral, Alfred Buachi. Our UMB partners include Justine Golden, Program Manager for the PhD in Gerontology program, Min Young Park, doctoral student and Gerontology Graduate Research Assistant, Dr. Hyun Jun Jun, Associate Professor in the Health Professions Education Program, Dr. Diane Martin, Associate Professor and Director of the GGEAR program. This series was created with the following objectives: to advance your personal understanding of dementia, to formulate realistic expectations based on the effects of dementia on persons living with ADRD and their caregivers, demonstrate confidence in interactions which reflects evidence-based, unbiased, culturally sensitive approaches to care, and create meaningful living opportunities for adults living with Alzheimer's disease or a related dementia in Maryland. A few housekeeping items. At this time, please be sure you have completed the pre-survey questions using your unique participant ID code listed on the Zoom invitation. A link to the pre-survey is available in the chat box. The Q&A box at the bottom of your screen is the place where you can drop in anytime to type in a question during the webinar or place a comment. The presenter will address your questions before the webinar concludes. If you are here today and would like continuing education credits, you must be present for the entire session. Due to the large number of CEU participants, we request that those seeking CEUs please stay connected and provide your full name and type of CEU in the chat at the end of the webinar. We request that everyone complete 2 things before you leave the webinar today: the post-event survey and the program evaluation. There is time allotted for completing these after the presenter will conclude her remarks. Closed captioning has been enabled. Just click the CC button at the bottom of your screen. If you don't see it, just hover your cursor near the bottom of the screen and it will appear. Everyone's audio has been muted for this webinar and it will be recorded. So let's begin. It's my pleasure to introduce Mark Tesoro, who will present our opening remarks. As the Maryland Department of Aging's Cognitive and Behavioral Health Specialist, Mark's role is part of a statewide effort to explore and address the challenges that impact healthy aging and longevity in Maryland. He focuses on expanding services that build the dementia capability of the Aging Services Network in collaboration with local area agencies on aging, state partners, and diverse stakeholders. Mark's work includes providing consultation, technical assistance, and oversight for the implementation of the recently enacted long term care and dementia care navigation legislation to be delivered by area agencies on aging. Mark, the residents of this state are grateful to you and your department for the innovative programs and services you provide each day. Welcome, and thank you for joining us today to kick off the series.
Well, thank you. That is just a lovely, lovely introduction, and I appreciate it. I'm going to see if I can start my screen here. I don't think I'm allowed to video here myself, so I don't know if you can give me permission to do so, because I always like to have the person be seen while I'm talking. So you should know who you're talking to. But it's okay if it's
try to make you a host, Mark, and I think maybe then your video will be able to come up.
Oh, okay. Thank you, Diane. Oh, there we go. Let's see here. There we are.
There you are.
Thank you. I appreciate it. And again, that's just such a lovely introduction, and I appreciate it. And thank you all for attending today. I did, I have the distinct pleasure. Let me share my screen if that's okay. Let me know if you could see my screen. Does that look okay, hopefully? Excellent.
Yep. If you could, there you go. Yep, you got it. Thank
Great.
you.
So again, I have absolutely the distinct pleasure of welcoming all of you to today's Navigating Dementia and Education series. I can tell you that you are all in for a treat, as this team from the University of Maryland, the Geriatrics and Gerontology Education Research Program, GGEAR, are just masters of gathering the latest information and really delivering it in a dynamic and thoughtful way. So people who live with dementia are probably some of the most challenging individuals to provide care for. They have both cognitive and behavioral health elements to understand and work with. Whether that be Alzheimer's disease or frontal lobe dementia or vascular dementia, they all tend to have different presentations. There's different strengths and weaknesses amongst the individuals. There are different disease courses. And it can be hard to navigate the condition, the services, and the support systems to help with these individuals. And sometimes it's just hard to know what questions to ask or even what to expect. So the goal of this series is to help provide information, to have the skills and the support and to feel comfortable working with people who are living with dementia. You're going to learn techniques and best practices that will help equip you to meet the needs of the individuals you're helping. You will be given suggestions and provided resources to help you find your way. This is extremely important work because as a state, we are aging. To give you an idea, over the next decade, there will be more Marylanders over the age of 60 than under 18 for the first time. And that translates to 1.7 million individuals. And to give you an idea of the size of that number, that's larger than the city of Phoenix. And for a more local flavor of the size of that number, it equates to filling both the Ravens Stadium and Camden Yards to capacity 15 times over. So tremendous, tremendous growth in this segment of the population. Half of all 5-year-olds today can expect to live to 100, which is a wonderful thing. A lot of folks go, oh my gosh, I don't want to live to 100, but it's a wonderful thing and a miracle of science, frankly. But when our 5-year-olds routinely start to live to 100, we're going to need to know how to handle that and how to work with those individuals. We need to work on improving our access to cognitive behavioral health services across the entire lifespan. Alzheimer's disease is increasing as we are simply living longer. 1 in 8 Marylanders over 65 and older are estimated to have Alzheimer's disease, and that's actually projected to increase by close to 20% by 2025. As February was Black History Month, I think we'd be remiss if we didn't mention that people of color tend to have higher rates of diabetes and cardiovascular disease and blood pressure, which increases their likelihood of dementia more than those who are white, and 1.5 times more likely among Hispanic individuals. But not only do people who are living with dementia have these kind of health issues, it's important to note that so do their caregivers. 68.8% of caregivers report having chronic health conditions, and 27, almost 30% of caregivers report having some level of depression. Because so often, I believe, caregivers are desperately trying to balance work, adult care, child care, and tend to ignore their own health, which is why we see these numbers and are concerned by them. So how is the state of Maryland trying to help? Well, earlier in this presentation, we were talking about this legislation that has been passed, this long-term care and dementia care navigation legislation, which really mandates our office at the Department of Aging, as well as with the AAAs, to bring more resources to bear on Alzheimer's disease and related dementias. So that involves conducting cognitive screening, delivering ADRD, Alzheimer's disease and related dementias programming, assisting in accessing local resources, helping navigate services and care referrals, hosting educations like these and awareness opportunities, providing caregiver support, as well as participating in outreach activities to help people get access to services. We are also very happy that on January 3rd, Governor Moore signed an executive order for what we're referring to as the Longevity Ready Maryland Initiative. Now, what that initiative is it directs the Maryland Department of Aging to prioritize the well-being and the need of older adults and people living with disabilities and their caregivers all across all state government. And that is something that's somewhat unusual for our office because it really means working with non-traditional partners that we haven't necessarily worked with before. So those would be folks in maybe transportation and housing and healthcare to make sure we're addressing the needs as this population grows. So this Longevity Ready Maryland Initiative is a long-term plan focusing our effort across the entire lifespan. And this series is part of these efforts and many more to follow in the coming years and months. We are embracing a very holistic approach to aging and supporting the process across the lifespan. So I want to thank you and welcome you for joining us today. And I hope you enjoy the wonderful opportunity that this is affording you. And the Department of Aging is just so proud to be supporting these efforts. Thank you, and I appreciate the time, and I hope you enjoy the experience.
Thank you so much, Mark, for your leadership, encouragement, and support of this series. So the details and learning objectives for today's webinar are available in the program book that was linked to the Zoom invitation. Please take a moment to review it. There are many resources in the book that will be useful to you. Right now, you can locate the note-taking guide on page 7. This is a supplement that allows you to follow along and include details to help you remember what you've learned. Webinar number 1 is entitled Understanding Cognitive Aging. differentiating between usual and unusual changes in memory. As we age, it's common to experience shifts in memory function, but distinguishing between what's potentially concerning can be challenging. This live interactive 90-minute webinar is designed to empower individuals, caregivers, and professionals in understanding the nuances of cognitive challenges. So the learning objectives for today are to describe the expected effects of aging on a variety of cognitive functions, to recognize 6 ways that memory and thinking change as part of the usual aging process, to create a framework by which to differentiate usual changes in cognition and memory from diseases and conditions that affect memory and cognition. And finally, to assemble a toolbox of tips and resources to promote brain health. Now it's my honor to introduce to you our presenter, Diane Martin, PhD. She's an associate professor, graduate school program director in aging and applied thanatology, program co-director in gerontology, and director of the Geriatrics and Gerontology Education and Research Program, GGEAR. Dr. Martin is a leader, educator, and scholar practitioner who has dedicated her career to developing impactful academic and non-academic activities in support of our rapidly aging population. As the director of the GGEAR program at UMB, Dr. Martin provides leadership on professional and interprofessional initiatives designed to enhance health professional training for those serving aging populations. You can learn more about her accomplishments in her bio in the program book. Dr. Martin has been an amazing mentor and friend to me over the years as I've pursued my passion in gerontology, and I can testify to her dedication, commitment, and versatility as she strives to improve aging outcomes for all of us. So our cognitive attention is all yours, Dr. Martin.
Thank you, Laura. I appreciate the introduction. And Mark, I appreciate you being here and the support that you've given us over the last 6 months as we've really tried to pull this program together. So really excited that we're ready to launch. And, you can't discuss dementia. Everybody says, well, let's talk about dementia. Let's talk about dementia. And even when this program first came up, people were saying, well, this is what we need to do for people that are living with a dementia and their caregivers. And I said, before we can think about what it means to have dementia or what is dementia, we really have to have an understanding of what are those usual changes of aging. And I think right now, more than ever, we need that because there's so much in our political discourse about the age of our president and the age of the other party's nominee for president, and about their cognitive well-being. And so I think this is a really pertinent topic to kick off the series, but also to help us to really understand that aging is not equivalent to dementia. Just because someone is growing older does not necessarily mean that they're going to age with a dementia. When we think about people over the age of 65, only about 10% of the population over the age of 65 has a dementia, but our risk factors do increase as we go through the aging process. And so I wanted to kick off the series, the Navigating Dementia series, by providing an overview of the usual aging processes, and then offer at the end some differentials that we should really be thinking about. And that'll set the stage for next week, next Friday's presentation with Dr. Majid, who's going to be delivering the webinar on differentiating between reversible causes of dementia and the irreversible causes of dementia. So give me just a moment. I'm going to set my timer so I make sure I have time here at the end for questions. And I'm also going to just pull up my screen share. And thumbs up if you can see this. Whoops. Perfect. Thank you so much. All right. So I titled this, Should I Be Concerned? I kind of gave that the pre-header there. Should I be concerned? Because everyone thinks as they're going through the aging process, any little memory slip, is this a symptom of a dementia? And one thing I want you to keep in the back of your mind is we all have memory slips. How many times have you come in from the end of the day, you're rushing off to take the kids someplace, or picking up your mom, or you're meeting your husband someplace, or your wife, and you drop your keys, and then you spend 20 minutes looking, where did I put those keys, right? We all do that. Stress can block our memory functioning. So, when we think about this, we really have to think about what are these usual changes and what are these unusual changes. So I have no conflicts of interest with this presentation. And as Laura said, here are my learning objectives for today. By the end of the day, or the end of this hour and a half or so, you should be able to describe the expected effects of aging on cognitive functioning, recognize again the 6 ways that memory and thinking change as a result of the aging process, create that toolbox of tips and resources to promote your own brain health and those of people that you love, and even people who are living with dementia. These tips are going to be good for everybody. And then evaluate that framework by which to differentiate between usual and unusual changes. So need to start with some basic definitions. When we're thinking about cognition and memory, those terms are oftentimes used interchangeably, but really memory is a part of our cognition. Memory or cognition is our thinking, our mental activity in the brain when a person is processing information, right? We're taking in information from our environment, we're thinking about it, maybe we're relating it to things that we already know so that it makes sense to us, and then we're storing it away. Those are our cognitive processes. Our memory is the power or process of reproducing or recalling what has been learned or retained. So once we get it stored away, it's bringing it back and using that information. And then intelligence refers to our ability to acquire and apply new skills. So I know, Laura, when we were putting this program book together, there are a lot of definitions in there, but these are the 3 that I want you to be familiar with as we go through the presentation this afternoon. So I'm going to take you back to an Intro to Psych class. Those of you who've taken Intro to Psych 101, around chapter 6 or chapter 7, about midway through the semester, you may remember learning about how our memory works. And so I just want to highlight that, because a lot of us think about memory as this, anything I put in my memory should be there for me to retrieve, and that's not necessarily true. So I want to walk you through this diagram of how memory works, and then we'll begin to think about the 6 ways that memory changes and cognition change as a result of the aging process. So over here in the incoming information, we have everything around our environment, right? So the sound of my voice, the image on the computer that you're looking at, the temperature of your room, whether you're warm or you're cold, that's entering your sensory memory. If you're eating or you're having something to drink, that tactile stimulation that you're receiving, the gustatory stimulation that you're receiving is all entering into your sensory memory. So it's the sights, the sounds, the taste, the feelings, the smells that are in our environment that we're processing, although we're usually unaware of this, right? So the incoming information reaches our sensory memory, and we're not paying attention to that a lot. A lot just kind of drifts away. We're not necessarily, until I just said it, you probably weren't focused on the temperature in the room that you're in. But as I bring your attention to it, it's able to move from our sensory memory into our short-term memory. So before we get there, let's talk a little bit about sensory memory. The 2 areas that are most well-researched are our visual sensory memory, so the things that we're seeing, and our auditory sensory memory, the things that we're hearing. And when we think about these 2 areas of our memory, their capacities are actually quite large, but the duration is only a fraction of a second. It's quickly replaced by new sounds or new sights, and only really what we pay attention to is what's making its way into our short-term memory. And so our short-term memory, When we think about short-term memory, there's oftentimes this misnomer that it's something that happened yesterday that's still in my short-term memory. Short-term memory refers to what we're processing right now, right, at any given moment. The duration is only about 10 to 30 seconds, depending on how long we're paying attention to it. Obviously, we can keep it in short-term memory for a longer period of time, but the duration is really only about 10 to 30 seconds unless we're really thinking about it. And we can only hold about 7 plus or minus 2 chunks of information. So about 5 to 9 pieces of information is what we can usually hold in our short-term memory for this brief duration. So think about it in terms of trying to remember a telephone. Those of us who are old enough to remember not having a cell phone that we were plugging telephone numbers into, but someone would give us their phone number and we would say it and try to remember it long enough that we could write it down, or you pull a pencil out and you write it on your hand, a pen on your hand. You're rehearsing it, you're saying it over and over again in order to hold on to it so that you can retain it. But that's a short bit of information. It's only about 9 digits, 10 digits if you include the area code and the telephone number. So you have 9 digits. So that's short enough or long enough to stay within our short-term memory. So we can rehearse this for a longer period of time. And the more we repeat it, the more likely it is to make it into our long-term memory. And here the capacity is quite large, right? And the duration, when we think about it, it could be a lifetime. That information may be stored away and we're just lacking the triggers to retrieve it. So we look at long-term memory as being a very large capacity with a very long duration. And within our long-term memory, we have 2 types of memories. We have declarative memories and non-declarative memories. Declarative memories are things that you declare, things that are easy to put into words. So things that you've experienced. Your episodic memory, like an episode from your life where you can tell me what you had for breakfast this morning, or what you did this past weekend, or the plans that you have for this weekend with your friends. That would be information that's in your episodic memory. It's an episode from your life. The second type of declarative memory is your semantic memory. And this is general knowledge, things that you've learned along the way. You may not remember how you learned them, but you know it nonetheless. Right? It's knowing that 2 times 2 is 4. You may not remember exactly where you were and how you learned that 2 times 2 is 4, but you know that it is nonetheless. The other type of memories that we have in long-term memory are our non-declarative memories. And these are memories that are difficult to put into words. We call them our procedural memory. It's our memory of how to do things. Things like, how do you drive a car? How do you ride a bike? How do you make a peanut butter and jelly sandwich? Right? If you had to explain to someone how to do those things, it would be very difficult to put that into words. And oftentimes we demonstrate, right? If I was in the room with you, I would tell you I ride a bike by holding it upright, putting my hands on the handlebars and steadying it, and then kicking my leg over the saddle so that I can ride it. But to put it into those words without actually showing you is really difficult to do. And so that's our procedural memory. You can think of procedural memory as the procedures we follow in order to carry out an activity. So that's the basic components of how memory works. Information from the environment makes its way into our sensory memory. Visual and auditory is what's most well researched and what we know the most about. So it's entering through our ears and through our eyes. A lot of that information is lost, but what we pay attention to is making its way to short-term memory. We can rehearse that information to keep it there long enough that we can use it. And then if we rehearse it long enough, and there are different types of rehearsal we're not going to talk about, but there are a couple of different types of rehearsal that get it into long-term memory. And then we store it away until we need to use it. And we get triggers, or someone asks us a question, which is a trigger, or a smell can trigger a memory, and we're able to pull it back to conscious awareness, which is returning it back to our short-term memory. And then we have those two types of long-term memories, the declarative and the non-declarative. So keep that in the back of your mind. And we're going to talk about how these processes change as a result of the aging process. And so there are 6 ways that our memories change. And the first way is with our senses, right? We know that with age, our senses begin to decline. Our hearing, our auditory senses begin to decline in our early 50s, especially for men. It can be more difficult to hear high-pitched sounds. A woman's voice is high-pitched, and so it may be more difficult to communicate. For some people, auditory changes can happen much younger in life. For example, kids today are using the earbuds and they're turning up the volume of their iPods and listening to that music, and they're doing some brain damage in there. People who have industrial jobs with the jackhammers, or they're working with heavy equipment, they may be losing their hearing at a younger age. But on average, about the age of 50 or so is really when we begin to notice these auditory changes. And as our hearing changes, it makes it more difficult to pick up information that's in the environment so that we can process it. And then the other type of change in our sense is our visual changes. Our vision begins to change in our 40s with our near vision. I remember when my kids were little and they needed something signed, and they'd come running home and they'd shove papers in my face for me to read and to sign. And the first thing I would do is push it back because I couldn't see it up close any longer, right? And then eventually needing to move to reading glasses. So these visual changes and the auditory changes make it more difficult for us to pick up information from our environment, right? So if we're not hearing very clearly or we're not seeing something, it may not make it into our sensory memory so that we can process it. So that's the first change, is with our senses. Our second change is with our attention. And our attention is what gets information from our sensory memory into our short-term memory so that we can actually work with it and use it. So attention is the ability to focus on pieces of information and decide what needs to be further processed. What is it that I need to be paying attention to in this environment so that I can retain that information for later use? And one thing we know about the aging process is that it does become more difficult to distinguish between relevant and irrelevant information as we grow older. So imagine, I know we have a lot of social workers in the audience. So imagine you're doing a home visit and you're visiting with a woman who's in her 80s, and grandkids are running around and they're chasing the dog and they're laughing and the dog's barking, and she has the TV on and it's blaring because she's a little bit hard of hearing, and you're trying to hold a conversation with her, right? There's a lot of distractions going on in that environment. She's got some visual distractions, she's got auditory distractions, she has environmental distractions. Maybe the temperature is a little hot in the room too, and so she's wanting to take off her sweater while you're trying to talk with her, and she's asking you to repeat herself. That's a normal part of the aging process, where being able to focus our attention on one thing becomes more difficult as we go through the aging process. So we are more easily distracted. It does take us a little bit longer to process the information. So what someone's telling you, it may need to be repeated a couple of times to ensure that it's actually being received by the person. It takes just a little bit longer to think through a response. If you've gone to a doctor's office, and doctors are very busy, they only have about 7 minutes to spend with their patients, and they're waiting for that older patient to tell them some of the complaints that they have. And they sometimes try to rush the patient because they don't have a lot of time. But the older patient does need a little bit more time to, number one, process the question that was asked, and also to formulate the response that they're going to provide. And there's the possibility of decreased accuracy as a result as well. So that's the second change that we experience. The third change is in our processing speed, which is the rate at which we process information and respond. And so another word for it is our fluid intelligence. And this is one of the intellectual abilities that does change as we go through the aging process. But look when it begins to change, right? It's not when we get to be an older person, it actually peaks when we're a young person. So it generally peaks during our mid-20s or so, but depending on our profession, or if we're continuing in school, it could actually continue to improve until our late 30s or even into our early 40s. But regardless, eventually it's going to stabilize until about the mid-50s or so, and then we begin to see changes, a slow decline in the way that we're processing information as we move into our 60s and to our 70s and then beyond. And give you an idea of processing speed, right? Remember, this is individual differences. We always talk about groups when we're thinking about these changes, normal and usual changes in aging, but there are individualized. You may be looking and saying, oh, I can still process information as well as I could when I was in my 30s. And you probably can. So, you know, we're thinking group differences, but there are obviously individual differences depending on your occupation, your level of education, how active you are. So cognitive decline is really selective when we think about that. But here in the orange line right here, this is our speed of processing. So you see here it's peaking in our late 20s, early 30s, and then stable, and then a decline that we begin to see as we move into our 60s and beyond. And this blue line represents our crystallized intelligence. And our crystallized intelligence, think about it like a crystal that just gets bigger and bigger and bigger over time. The stalactites and the stalagmites that you've seen in caves, and just over time, how they're just growing and enlarging. And that's what's happening with our second type of intelligence, which is called our crystallized intelligence. And our crystallized intelligence is our long-term memories. When we think about our semantic memory that we talked about before, when we think about our word knowledge, you maybe remember taking the SATs when you were in high school, and some of those words you may have been able to recognize, but not necessarily use in a sentence. But today, maybe you not only can use them in a sentence, but you can recognize them. I'm sorry, you can not only recognize them, but you can probably use them in a sentence as well. This is our general knowledge just increases as we go through. We have so much more experiences that we're able to draw on and inform our decision-making, our word choices, whatever it might be. It's like a crystal that gets bigger and bigger and bigger over time. So when we think of wisdom, we can kind of think of our crystallized intelligence. So when you think about all this decline that we're seeing here in activities like, if you've ever taken a cognitive assessment, we're asking you to do digit symbols and letter comparisons, things that we're not doing on a regular basis. It takes us a little bit of time to be able to do that. And we do decline with that as we go through the aging process. But then look at these reds and oranges and these gold. Our vocabulary improves as we go through the aging process. Our ability to make connections improves as we go through the aging process. And that's because of our crystallized intelligence. So that was our third change, is in the processing speed. So where we do see a decline in our fluid intelligence, we actually see an increase in our crystallized intelligence. The fourth change is in our working memory, and working memory is part of our short-term memory. It's the information that we are using to transform for example, you're at the grocery store and you're paying with cash, and the cashier tells you that your bill comes to $11.43. And you want to pay with cash, so you're holding on to what she says, $11.43. And then you're thinking to yourself, what types of bills and change do I need to put together in order to pay the $11.43? So your working memory involves the manipulation. You're maybe doing some subtraction in your own head to kind of figure out how much change you're going to get back. So you're basically transforming the information that the cashier is giving you into something that makes sense to you so you can actually pay the bill. And that's called a working memory. And this is one of those changes that we see, part of that short-term memory change, where we need to hold on to that information in our memory as we figure out what bills to use. But it's a complex task that takes a little bit longer to complete. And if our attention is diverted for some reason, we may lose it very quickly, because remember, this short-term memory only has about a 30-second capacity unless we're really working with it. So going back to that example of being in a grocery store, imagine the cashier tells you your bill is $11.43. You're paying with $15. So in your mind, you're trying to calculate how much money, how much change you're going to get back. And someone comes up behind you and accidentally hits you with their shopping cart. And your attention diverts from the cashier and thinking about the change to just turning around real quick to see what happened, right? And you go back to the cashier and say, can you tell me how much that was again? Right? Because you just lost that information when it was diverted. Your attention was diverted for that reason. So that is another one of those changes that we see as a normal part of the aging process about working memory. What doesn't change is that capacity, right? We said the capacity of our short-term memory, this working memory, is about 7 to 9 pieces of information. That doesn't change as a result of the aging process. When you're 18 years old, your capacity is about 5 to 9 pieces of information. When you're 90 years old, your capacity is about 5 to 9 pieces of information. So the capacity doesn't change. What changes is the way that you're able to transform that information. And oftentimes it's also related to changes in attention that we experience as a result of the aging process. So that's the fourth change. The fifth change is the way that we move information from our short-term memory to long-term memory, right? You might remember being a child and learning the, let's see, we'll choose the names of the planets in the correct order, right? And so your teachers gave you mnemonic devices, these tips and tricks to help you to remember those planets. When you're studying for a test, you fall back on those mnemonic devices. So the mnemonic device for the planets in the correct order, the one I learned was, my very energetic mother just served us 9 pizzas, when Pluto is still considered a planet, right? So that first letter, each letter represents the first letter of the planets in the correct order. So when we're thinking about encoding, transferring that information from short-term memory to long-term memory, as children, we learned, as young adults, we used, as midlife adults, we used this elaborative rehearsal to help us to remember this type of information. But something happens when we go into later life. We don't spontaneously rely on it the way that we do when we're young adults and midlife adults. If triggered, we could, I could tell you, my mom, who's 70, she'll be 77 this month. And if I asked her the planets, she would in her mind try manipulating them and saying, and coming up with them. And I'm like, Mom, remember the acronym or the mnemonic, my very energetic mother. And she would be able to spit it out, right? But to come up with that, remember that there was a mnemonic that went along with it, or to use that mnemonic, it does become a little trickier as we go through the aging process. So that's another one of the normal age-related changes, is relying on some of these tips that we used and tricks we used when we were younger. And then the last change that we experience as a result of the normal aging or usual aging process is change in our episodic memory, right? We said episodic memory is the episodes from our life, things that we've experienced, things that we've witnessed. As we go through the aging process, it can become a little bit fuzzier, right? Not traumatic memories, the birth of your child, you'll remember that. I was in college when Challenger exploded. I can tell you exactly where I was when that happened. I can remember where I was when I heard Reagan got shot, right? So those more traumatic memories kind of stick with us. But other day-to-day memories, I don't remember things that I did with my childhood friends or who my teachers were when I was in elementary school. Those episodic memories do begin to fade as we go through the aging process. So those personal experiences, but the semantic memory, the procedural memories, they don't fade. Semantic memory gets stronger as we go through the aging process. Procedures, we don't forget how to drive a car. We don't forget under usual processes. We don't forget how to turn on or off a light. We don't forget how to tie our shoes or how to ride a bike. It comes back to us if we haven't ridden a bike in a while. So to go back, we started with Psych 101, and we're going to move in. Now you're a junior and you're learning about adult development and how the memory changes. So in your junior level psych class, you would learn everything we just talked about, how the environment, the changes here in the incoming information may not reach our sensory memory because of changes in our auditory system or our visual system or really any of our senses. We need to pay attention as we go through the aging process because attention is a second decline that we see under usual aging processes. Short-term memory capacity does not change, but our ability to manipulate and work with that information does change, especially if our attention is diverted. The way that we encode information, we rely more on maintenance rehearsal, which is repetition, compared to making connections, like remembering the mnemonic device or remembering where you were when something happened. That episode or that elaborative rehearsal does change as a result. We don't lose it. We just have to be reminded to use it. And then within the declarative memories, it's our episodic memory down here that changes as a result of the aging process. So we do have 6 changes in our memory and cognition that are considered to be normal aging processes. Before I move into why the changes, does anyone have any questions? Where does working memory fits into short-term memory? Thank you. All right, so why do we experience these changes? I kind of gave a few hints as we went along, but let's spend some time thinking about why these changes are occurring. The social determinants of health, right? When we think about access to quality health care, access, especially when we're young, access to quality food, quality education, those are really, really important to cognitive health as we go through the aging process. I've read some literature recently that there seem to be 3 very critical periods that can set up risk factors for dementia. The first being in early childhood with lack of healthy foods and poor education can set someone up for cognitive decline in later life. The second happens in midlife, which is when you're a child, you don't have any control over your environment, right? You don't have any control over how much exercise perhaps that you're getting or what kinds of foods that you're eating or the quality of your education. So that happens in childhood and that happens to us. But then in midlife, it can be choices that we're making for ourselves, like smoking or not exercising, being that couch potato and not exercising, not eating healthy, right? We're sitting on the couch eating our potato chips and we're not exercising or eating healthy fruits and vegetables. Obesity is a risk factor for a lot of diseases in later life. And when we think about unhealthy lifestyles, is also a risk factor for dementia in later life. And then the third time period is later life itself. It's that social isolation, that lack of connectedness and stimulation. So I'm going to talk about that later, and that's what you'll really be getting from a lot of these webinars, is how to promote that as we go through the aging process. But just kind of think about that in terms of the social determinants of health when we think about the environment that someone's living in, even in midlife, right? We can say, well, you know, it's a lifestyle choice to not exercise, but what if you're not living in a safe environment, right? And to be able to go outside and walk around the block, right? Or to have pollution that's interfering with your ability to breathe fresh air. So those social determinants of health are really important. So socioeconomic status, we can tie somewhat to that when we're thinking about, you know, you can go to McDonald's and get a burger, fries, and a soda for about $4, $5, compared to going to the store. The healthiest parts of the food, the grocery store, is that perimeter where you walk in and you've got your fresh fruits and vegetables, your fresh meats, and then your dairy and your yogurts and everything, your eggs and everything. So when you're walking that perimeter, but that's also the most expensive part of the grocery store, right? So if you don't have a good income, you're not going to be able to walk that perimeter of the store. You're going to be going inside aisles and getting the more unhealthy foods like the chips, or going to McDonald's and getting the hamburger and the fries through the drive-through. So income can determine, lead to more rapid decline. Lack of education. I said before, in childhood that poor access to quality education, but not remaining active and stimulated in your environment, whether it's through lifelong learning or just, you know, reading through you know, I want to say the encyclopedia, but I don't think people do that anymore. But, you know, just reading news stories and staying active, cognitively active. And then occupation, obviously, that's part of our socioeconomic status as well. Gender, historically, women weren't going to college and getting the higher education. So we did see, when I first got into the field in the 1980s, we did see that women had higher rates of cognitive decline. Cultural differences, again, when we're thinking about women and even children, girls that are denied access to education, that all plays a role in it. And this image that you're seeing here is just the brain activity of someone who has a lower socioeconomic status compared to the cognitive stimulation of someone who has greater access. A second reason for change is just normal age-related brain changes. Physiologically, what you're looking at here is a neuron. And so here we see the normal brain aging. This is your nucleus down here, which is the brain of the nerve cell. It's where all the information is being processed. Down here, these are called dendrites, and that's the receiving end. So they're receiving information from all of the surrounding neurons, sending it up here to the nucleus for processing. The nucleus determines whether or not this is a message intended for that cell type. And if yes, it sends it down here. This is called the axon. It sends it down here and makes its way out to these tips, and it keeps firing like that. And that's you know, what's happening in the healthy young brains. As we go through the aging process, we go through what's called dendritic pruning. Possibly there's a lot of literature that says, yes, this happens, but there's also a lot of literature that is questioning that. And dendritic pruning just means these receiving ends down here may be clipped as we go through the aging process. And just for comparison, this is the neuron of someone who is aging with a dementia. So here's your nucleus. but look, here's the receiving end, that dendrite down here, and then down here, where that information is supposed to be sent out. So there's been a lot of change. But then even in normal brain aging, we see some changes. That's what you're looking at here. And so where is this happening? In two areas of the brain. So in normal aging processes, it's happening in two areas of our brain. The cerebral cortex, which if you opened up your skull and you look down and you'd see a shiny area of your brain, it's about a 1/4 inch thick. And if we were to lay it out, it would be about a 2 foot by 2 foot area. This is pushed together and it has lots of fissures and grooves that you're looking at right here. All these little indents, these fissures and grooves they're called, and that helps information make it, those neurons to transfer information very quickly from one part of the brain to another part. And what we see as a result of the aging process is that cerebral cortex, we begin to lose neurons within that part of our brain, about 5% neuronal loss by about the age of 70. This is normal aging. 10% by the age of 80, and about 20% lost by the age of 90. Usual aging. We're not talking about someone who's going out and remaining cognitively active and socially engaged and physically active. This is your usual person who is slowing down with the aging process. So we see the most marked declines within that cerebral cortex in two areas of the brain as well, within the frontal lobes, which is right here, 2 finger lengths above your eyebrows. It begins and it kind of wraps around. You see this you see that pinkish area right there. That's your frontal lobes, and your frontal lobes are responsible for some really important things when it comes to memory and cognition, right? We talked about the importance of attention. That's the role of the frontal lobes. Planning, reasoning, making decisions, impulse control, and then ultimately memory are all within those frontal lobes. So we do see decline, marked decline in the usual aging processes as someone's growing older. And then the other area we see decline is in this little area right here that's called the hippocampus. And it's a funny name, but it is a really important feature for learning and memory, right? So we see some cognitive or some neuronal cell loss within this area of the brain. This is the part of the brain that takes in information and converts those short-term memories into the more permanent long-term memories. And then when you need to use it, it's the hippocampus that retrieves it from long-term memory storage back to short-term memory so that you can actually use it. So it's a really important structure for learning and memory that aids in those memory conversions from short-term to long-term and then back again. A third explanation for these usual memory declines are medical conditions. When we think about we talked about those chronic illnesses that onset oftentimes in midlife, when we think about high blood pressure, when we think about heart disease, diabetes, thyroid conditions, right? All of those medical conditions can have an impact on our memory and our cognitive functioning. Medication interactions, when we think about polypharmacy and whether a medication, when you take a look at the warning labels that come with your prescriptions, or even what we hear on the television, those medication interactions can interfere with our memory system and our cognition. So polypharmacy, and that's something we're going to be talking about later in the series in one of the in-person sessions. We have a pharmacist who's going to be talking about the Beers criteria, which is medication that's oftentimes ill-advised to prescribe to older adults because of the impact that it can have. But just to put it in perspective for you, things that you might have in your medicine cabinet at home, when we think about sleep aids, right? When we think about taking NyQuil, if we have a cold or a flu, if we can't sleep and maybe we have a little bit of arthritic pain, and so we say, oh, I'm going to grab some Tylenol PM or some Advil PM. Those medications can actually interfere not just in the short term, but over time with our memory and our cognitive functioning. So medication interactions, and again, looking at those Beers criteria is going to be a big part of one of the in-person conferences later, I think in May, the May 10th conference, we're going to be talking about that. And then mental health. When we think about our stress levels, depression, anxiety, that plays a role in our memory and cognitive function as well. So I'm going to jump ahead. I'll come back to that. Maybe not. Yeah, I'll jump ahead later to that. But mental health, just kind of keep that in the back of your mind, that depression can oftentimes lead to some cognitive decline. And then it becomes really important to recognize that it's a depression and not cognitive decline. And I've got a story to go along with that. So there are also psychosocial explanations when we think we've talked about already the lack of the stimulating environment, the lifestyle choices, and then the psychological factors. So we'll talk about that next. But thinking about social isolation, right? We heard a lot about this and a lot of concerns coming out with COVID about older adults who were becoming isolated in their homes or even in the skilled nursing and the continuing care communities. And what was that doing to their cognitive health? We know that brain engagement is really, really important for cognitive function, for memory. And so we did see a more rapid decline. I read a report not too long ago that was sounding the alarm that children today, young adults today, who are spending so much time on social media and not interacting, are placing themselves at greater risk for cognitive decline in later life. And that was just, I think 2 weeks ago, I saw that. So if I find that, I'll find that article and we can send that along as a resource. But it kind of sounded alarms that, you know, if your child is spending a lot of time on social media or on their computer and they're not interacting with their peers and they're not engaged, what are they doing to their cognitive health moving into the future? Lifestyle, again, thinking about childhood that we don't have a lot of choice on compared to things that we do have choice when we think about our midlife choices on what we're eating, what we're drinking, how much we're exercising, or if at all, that all plays a role in our cognitive health. And then these psychological factors. And so when we think about anxiety and depression, it's really important that we raise those red flags to really understand some of those differences. And I said I have a story to share. Years and years and years ago, I got my start. My career started at the Johns Hopkins Alzheimer's Disease Research Center back in the late 80s. And one of my roles was to identify people who had been newly diagnosed by their primary care physician with a dementia. Back in the late 80s, early 90s, 1990s was actually dubbed the decade of the brain. There was a lot of federal money coming into research to understand Alzheimer's disease and other dementias. And so my job, I had a twofold position. One was to identify prospective participants and invite them into our research study. And the other was to do the cognitive assessments, the neurocognitive assessments, the true battery, not just, take this quick test, but I would spend about 3 hours going through an entire series of neurocognitive assessments. And we had both healthy aging individuals, people that we weren't concerned had a cognitive decline. And then we had our patients that did have some type of a dementia. And back then, everything was called Alzheimer's disease. And I would see my patients every 6 months. So I'd be charting cognitive decline over time. And back in the late 80s, early 90s, life expectancy was about 7 years from diagnosis to death. And we could see decline every 6 months. We could see pretty good sharp decline and begin marking what Alzheimer's disease dementia actually looked like. And I'll never forget this woman came with her husband. Her husband was a psychiatrist, and the primary care physician diagnosed her with dementia. And the husband, again, he's a medical doctor, he's a psychiatrist, and that's what he thought she had as well. And oops, sorry. And she comes into my clinic and I'm doing her cognitive assessments, and she comes back later, 6 months later, and doing cognitive assessments, and she's not progressing the way that a patient that we would typically see with a dementia like an Alzheimer's disease was progressing. And so we kind of put her on our own category over there. We watched, and she survived. She was very young. She was only about 56 or 55 years old. And from the time she came to our clinic, again, newly diagnosed, she died, I think, within about 2.5 years or so. So we had about 4 or 5 data points for her. And as part of the clinical assessment we did, we were an interprofessional team. And so I was the neuropsychologist. So I did all the memory assessments. I worked with Marshall Fulstein, who was a psychiatrist. We had a neurologist, Dr. Claudia Kawas. We had a pathologist on our team. We all, after death, we would do case reviews, and the pathologist was there to reveal the cause of death, or what the diagnosis actually was. And when we were doing this patient, nothing in her chart, none of her medical exams, her cognitive exams, her neurologic exams, nothing represented Alzheimer's disease. And we were stumped. We had no idea what this poor woman had. And then the pathologist revealed it was a depression, untreated depression. And it mimicked the dementia so much so that the primary care physician, her husband, us, we didn't recognize it. So it's really important that these full examinations be done. Now we know so much more. Here we are, 35 years later, 30 years later, we know so much more. And so there are red flags that help us to distinguish between depression, which is a psychological factor, and dementia. So usually when someone has a depression, it's an acute onset, right? You can pinpoint when there was a change in memory or a change in behavior. It's a very rapid progression, and the person complains that their memory is just not what it used to be, right? They're having difficulty concentrating or making decisions. And the person will oftentimes emphasize their cognitive complaints. Anyone who will listen, the person will complain about their memory. They'll highlight their personal failures, which we don't often see in someone with a dementia. They don't make a lot of effort to complete tasks. They don't try to keep up. And when you look at them, they're clearly in distress compared to someone who has a dementia. And what we see in a dementia, in contrast, is a slow progression over time. So it's not going to be waking up and seeing a very acute difference from day to day, but we could see that in a short term in someone who has depression. Someone with a dementia will oftentimes try to hide their symptoms, right? So they'll brush it off. Oh, I didn't sleep very well last night, or I'm tired now. Ask me later. My memory will be better later after I get a little bit of rest. So they try to conceal it or explain away their concerns. They emphasize their accomplishments, right? This is what I can do. Don't pay attention over here to what I can't do. Look at how great I'm doing over here. But yet they're struggling with the task that they're trying to complete. And so they're oftentimes relying on notes and calendars. Another patient that I interacted with when I was at the ADRC was an engineer, and nobody knew. He worked in an office by himself, and nobody recognized the symptoms. And his wife said one day she brought him lunch, and his office was just filled with notes, turn this lever first, and just step 1, step 2, step 3. And that was the first time that she saw like any concerns whatsoever. So a lot of additional notes and calendars in order to try to keep up. They try to conceal it. They don't seem concerned about it, maybe on the outward, but inside they are, and that's why they're using those notes and such. But being aware of how are these symptoms presenting? How is the person responding to these symptoms? It can help us to begin to differentiate between whether this is a mental health concern or a type of a dementia possibly that's beginning to onset. And then obviously we always have other explanations, right? As we go through the aging process, we all look forward to retirement, and all of a sudden my responsibilities are gone, right? So my memory is not going to be so great because I don't have to keep up with all those 100 billion tests that I've been trying to keep in my mind for 30 years worth of work. So these changing responsibilities can look like memory concerns, when in fact it's just we're changing our lifestyle, right? We're slowing down in our work responsibilities, and as a result, we're beginning to see some slowing down in our cognitive and memory as well. And then I want to conclude this section with just this. We have this really inaccurate assumption about how our memory works. We think about it as being like a computer chip where, like my computer I'm sitting in front of, right? I'm making my PowerPoint, I hit save, I give it a name, and I store it. And then I just have to remember that name, bring it back up, and I'm able to share it with you. And we, for some reason, we think our brains work like that computer chip, when in fact they don't, right? We may not have the right cues to be able to retrieve that information. We may not store it accurately. Again, that idea of, are we using a maintenance, that kind of repetition to remember something, or are we trying to make connections so that we're able to remember it? So that idea of spontaneously remembering and making those connections, that's one of those things that we do see decline as a result of the aging process. Yet we expect that grandma's going to remember everything because this memory is like a computer chip. So we as a society have this really inaccurate assumption about how our memory system actually works. All right, I'm going to stop here and see if there's any questions that need to be answered before I talk about how we improve our cognitive function. Yeah, not using our brain. Yeah. I'll never forget. I went to, my husband and I went to a fast food restaurant many years ago, and we gave the young woman, we so confused her. And we're waiting for our change. The bill was something like $12 and some change. And I think we gave exact, the coin change. And she had to give us back like $3 or something. And my husband and I are waiting, and we're waiting, and we're waiting. Well, she pulls out her phone, and we thought she was calling somebody or answering a text. And so we walked away. We thought, oh, that's okay. We'll just let her keep it. And we stepped away, and she's like, wait, hold on. I have your change. She was using her phone to calculate how much change to give us back, right? So not using our brain when we rely on all these other tools, that's going to interfere with our memory over the long term. It's many young people interacting with their peers online, on video games, not always isolated activity. Is that a negative impact? That's what that research article said, yes. So I'm going to find that, and when we send some resources, we'll add that article as well, and we'll annotate it for you because it is a scientific article. Is there a test for primary depression versus primary dementia? One of our speakers at the May 10th, which is going to be that in-person session, we have two presenters. We have many presenters that day, but one is a clinical psychiatrist who specializes also in dementia. And so she'll spend some time differentiating with some of the clinical tools and non-clinical tools, more importantly, the non-clinical tools that we can use to look for primary depression versus that primary dementia. So stay tuned. Long-term impact of social isolation brought about by COVID. Yeah, we're just beginning to see that research come out now, Liz. Can we expect to see ramifications of isolation down the road? Yeah, that's what that younger cohort study was looking at specifically. Yeah. Vina asked, I was kind of on the fence whether we're going to be giving out the PowerPoints or not, because there's not a whole lot on the actual slides, I guess, other than the memory piece of it. We put so much information into the booklet. And the video, we're creating an on-demand video that'll be housed at university and then linked also to the Department of Aging. So this video is actually going to be available with on demand later this summer. She did. That's exactly anonymous attendee. That's exactly what the pathologist determined, that she died in her 50s because of untreated depression.
Diane, if you could just take a moment to just recap the earlier part of your slides at the beginning when you talked about the 6 ways that memory and thinking change as we age, so that everyone has that for their book.
Sure.
Thank you.
We'll just go right back to the slide. So 6 ways our memory changes. Our senses obviously change. And so if our senses are beginning to weaken, right there, we can't detect sounds, like the high-pitched sounds become more difficult to hear. Our vision begins to change. And so if we can't detect information in our environment, it does not make its way into sensory memory so that it can be processed and attended to for short-term memory. Just as an example of how our senses change, and we don't think about it until we're exposed to something that we can't hear, like a high-pitched. If we were doing this in person, I do the mosquito ringtones, and this is what an 18-year-old can hear. And I go through like 18, 24, 30, etc. And it's always amazing, half the room, their hand doesn't go up until I get to, this is what your average 50-year-old should be able to hear. In England, some of the shops used mosquito ringtones outside because the teenagers were loitering outside the stores. And so they had these high-pitched sounds that their older shoppers who they wanted to go into the store couldn't hear, but it kept the young people from loitering because it was such a piercing sound, right? So that's a good example of how our auditory senses change. Like an older person could not actually hear that sound. And you've probably seen that different places that have these. I know a friend of my husband's, the fence, animals can detect higher pitched sounds. And so the type of fence he has, it radiates this sound that humans, it's indetectable to humans, but animals will keep away. So number 1 is change in our senses. Number 2 is changes in our attention. It does become more difficult to distinguish what should I be paying attention to compared to what I shouldn't be paying attention to when there's a lot of noise. And noise is not just what we hear, but it's any unwanted information that's entering our sensory system. So that's number 2. Number 3, it takes a little bit longer to process information. So our fluid intelligence begins to decline, the speed at which we process information. But remember, as we go through the aging process, we actually increase in our crystallized intelligence, right? So this blue line, we get better over time, but the rate at which we can react and respond actually declines over time. It takes us a little bit longer to process information. But when we say it, it's great. We give a really great answer. It's that crystallized intelligence that draws on all of our previous experiences. Number 4 is our working memory. Remember, within short-term memory, we have our working memory. That's what begins to decline. But our capacity within there's no change as a result of the aging process. And then number 5 is encoding, right? The way that we get information from short-term memory to long-term memory. We rely more on repetition compared to making connections. But again, it's not that we can't make connections when we're reminded to. You say something like, Mom, that was just like when. And then you make that connection, and then they'll begin to make those connections as well under usual aging processes. And number 6 is that episodic memory, these personal experiences, things that happened to us, as long as they weren't traumatic. These personal experiences, I couldn't tell you today the name of my 3rd grade teacher, even though, I spent 10 months with the person.
Diane, there's one more question about the types of dementia that were kind of mentioned earlier from Autumn.
Yeah, I didn't mention these, but maybe Kate, Autumn's a friend of my daughter's. Maybe Katie had mentioned that to you. So Alzheimer's disease is the leading cause. Vascular dementia is number 2. Lewy body dementia is number 3, and then frontal temporal dementia, that frontal lobe dementia, is number 4. And that's going to actually be next week's webinar. All right, so let's take a couple of minutes to think about how can we improve cognitive function, and then I will just highlight prepping for next week's March 8th webinar on neurocognitive decline as well. So can our brain actually improve, right? Can our cognitive performance, can our memory improve brain games? And if you've taken a look through the booklet, you probably saw that Laura toward the end put some crossword puzzles in there for you, some word searches, the idea of stimulating our brain. So whether we're playing Sudoku, doing Rubik's Cube, something that challenges us, right? So yes, we can improve our cognitive function if we engage in activities that challenge us, right? So not something, playing Go Fish all the time, which is great with kids, but if you're getting together with your friends, maybe Go Fish is not the game that you should be playing. Something that teaches us, something that can build on our skills, that can improve our cognitive function over time. So learning something new and then progressing through that. So we start, down here at the lower level, and we're working our way up so that we can eventually perhaps teach someone else as well. So really anything that engages our brain, that's rewarding, because if it's rewarding to us, we're going to want to continue engaging in that activity. And things that are new, right? Our brain really responds to these things that can be novel. It gets all of our neurons firing and interested in it. And so if we can tie something new that's rewarding, that challenges us, and that's progressive, is really the best way to improve when we're thinking about games, to improve cognitive functioning. But lots of other things. So yes, keeping our brain active and engaged is one thing we should all be doing. But another, obviously, is making good lifestyle choices. I said before that, we don't have a lot of control when we're children. Obviously, you can choose to sit and play video games compared to running around outside. And it's up to us as parents to push our kids to go run around outside. So making these healthy lifestyle choices for ourselves, for our children when they're young, because as Mark said in his opening remarks, a child today has a 50% chance of living to be 100. And what do we want that life to look like, right? So remaining active when we're young, moving into midlife, making healthy lifestyle choices as we go through life, going to our doctor's visits, right? Following the doctor's recommendations for controlling our blood pressure, reducing our stress levels, maybe taking medicine if that's what we need to do, getting a good night's sleep, trying to get as best you can those 6 to 8 hours of sleep at night, stress-free. So if you have to meditate or take a nice walk before you go to bed, is a good tip. Obviously, eating a healthy diet. When you're at the grocery store, and I know the grocery store, again, I said that the perimeter of the grocery store is where you should be shopping. That's where all the fresh fruits and vegetables and fresh meats and dairy products are located. Look for the brightly colored fruits and vegetables. So, if you have a choice between green peppers and red peppers, you go with the red peppers. The blueberries obviously are good for brain health. Farmers markets, we're coming into spring and then into summer. So I know there's a lot of co-ops and a lot of farm markets that are going to be opening up. So anytime you can get these fresh fruits and vegetables compared to going fast food or shopping in the interior of the grocery store. But again, I know that's also economic dependent. And if you saw through the slides, I know that the Department of Aging has some possible resources that may be able to connect you to help you to eat more nutritious meals. Meals on Wheels obviously is available to some people. Keeping physically active, right? But again, environmentally dependent. So if you live in the city, that's not a very safe neighborhood. How are you going to get out and not be fearful? So those are important considerations. And then connection with family and friends, even if it's, on a Zoom call. My mom lives in Kentucky, so a Zoom call with my mom and staying connected with her, or a phone call. Just anything, and not just, so what'd you do today? But actually, some stimulating conversations. So when should you be concerned? It's normal, right? We've talked about stress and coming home at the end of the day, and you've got to run out someplace, but you come in the house and you drop your keys, and then you spend 10 minutes looking for your keys. Stress blocks, or the stress hormone cortisol blocks the flow of the neurotransmitter that we need for learning and our memory. And so my mom's calling me now. Let me hang up on her. Sorry, Mom. So, anytime that we can reduce stress, whether we're going for a walk, we're meditating, just trying to relax, is going to help our memory. But what's normal? It's normal to forget your PIN number, or even where you parked. If you're like me, you've come into a crowded parking lot, and maybe when you parked, there weren't a whole lot of cars there, and then you come out and there's everybody there and you can't find your car. And so, I'll walk around with my keys, honking the horn, looking for my car. That's normal. Forgetting what you were about to say, right? Where it's on the tip of your tongue, it was right there, and then maybe another thought came into your mind and you lost what you were going to say. That's completely normal. Forgetting the day that you had a dental appointment. That's completely normal. So using that little reminder on the calendar. Forgetting the name of the person you used to know, your childhood friends. There's nothing abnormal about that. Maybe you pass someone on the street and you look at them and you're like, I know you. Where do I know you from? And you can't come up with their name. Completely normal. But what's not normal is forgetting what an ATM card is for, right? Or what kind of car you own, or opening up the fridge and finding your car keys in the fridge instead of on the counter. Forgetting how to do an everyday task, like writing a check. Going out for a walk and getting lost in your own neighborhood is a red flag. Forgetting who your own family members are is a red flag. And so the last couple of minutes, I do want to just set the stage for next week's presentation. For those of you who are going to be joining us next week, the topic is going to be differentiating between the reversible. About 10% of dementia cases are reversible. Polypharmacy, infection, thyroid, things like that count for about 10% of dementia cases. 90% of dementia cases are not reversible. And so Dr. Majid is going to be talking primarily about those 90% of cases. But neurocognitive disorder, when we think about dementia, dementia today in the medical world is actually called neurocognitive disorder. In the Diagnostic and Statistical Manual, it's referred to as a neurocognitive disorder. So there are actually two types, mild disorder as well as major disorder. So when we think about mild neurocognitive decline, there's not, it's impactful, but it is less significant. It doesn't necessarily interfere when we think about our activities of daily living, like bathing and grooming and getting dressed and things like that, or what we call our instrumental activities of daily living, which are the business of living. When we think about going shopping, meal preparation, housekeeping, yard work, these more mild neurocognitive disorder doesn't interfere with that. It's noticeable, but you can still maintain your lifestyle. It might take a little bit more effort. So it is considered to be a less severe form of cognitive decline. Major neurocognitive disorder is much more significant. It does begin to interfere with our everyday activities. We see much more significant cognitive decline from what we consider to be that previous level of performance, that I was up here and now all of a sudden dad's down here. And it has to be in one or more of these cognitive domains of complex attention, executive functioning, learning and memory, language, perceptual motor skills, or social cognition. So when we see a change in at least one of those areas that's impacting our ability to carry out regular activities and our independence, that's what we're looking for in a neurocognitive disorder or dementia. And I want to just leave you with some examples of what we mean by complex attention, all of these 6 domains, to just get you thinking about everything that we've talked about and now differentiating between these red flags. So complex attention, we might see that a normal task that someone of equivalent age and ability would be able to complete in less time. These normal tasks are taking a person longer than it previously would have taken them. There's more errors in the activities that they're doing, balancing the checkbook and doing a lot of math miscalculations, for example, and so overdrawing the bank book. So needing to have your work double checked more frequently. We talked about the importance of a reduced noise in our environments under usual aging processes, because of the dog running around, the kids laughing, the TV blaring, the windows blowing in the cold air, and all that noise can interfere with our attention. When it is even more severe than that, when thinking is easier, when there's nothing competing with other things that kind of have to have complete focus on the task. There can't be any background noise or anything like that. That's complex attention, and if that's when the ability is the best, that's a red flag. Executive function refers to things like making decisions. So when someone's saying that they're getting tired out from doing an important decision making, or they just can't think about it right now, wanting to leave interactions with others, they're becoming less enjoyable because of the increased cognitive load, the amount of time and focus you have to have in order to maintain those conversations. That's a red flag. Planning, executive function. So when we think about executive function, think about it in terms of the frontal lobes. Remember up here, we talked about, where are they? The frontal lobes being responsible for attention, planning, decision-making, impulse control, and memory. So when we see errors in this or complaints about the difficulty, and again, they'll try to hide it, but complaining about, well, I need to leave this because I'm just tired, or just paying attention to the body language of the individual can tell us a lot. Yeah, so increased difficulty in multitasking, difficulty following directions, making that multi-stage completion. Two others, learning and memory. So difficulty recalling recent events. We talked about those past events, but when there's difficulty in more recent events, or there's an increased reliance on writing things down, like the gentleman, the engineer I told you about, who his wife came for lunch and there were lists and labels for absolutely everything. When we have that increased reliance on labeling and list making, repeating to the same person over a short period of time is a red flag. Losing track over what bills perhaps have been paid. Language difficulties, more difficult, right? I said we all have those instances where we can't come up with the word that we want to say, but when there's noticeable word finding difficulty, when they're substituting general terms. I have a German Shepherd, right? And so anybody who knows me knows that I raised German Shepherds. I've raised German Shepherds, 80 years, my family's been involved in German Shepherds. Imagine my mom, and she doesn't have a dementia, but imagine my mom who's 77 years old and all of a sudden can't think about come up with the name of the type of dog that we breed, right? And she just calls it a dog, or she says big dog, right? That would be obviously a concern. May avoid use of specific names of acquaintances. Again, it's normal not to, to have that name and you're thinking about it. Oftentimes we'll go through the alphabet trying to come up with that person's name. But when we go out of our way to avoid using that person's name, that can be a red flag. Incorrect use of the word choices. And then we have two others, perceptual and motor abilities, relying more on directions or using a map to get from point A to point B when it may have been trips that they've taken all the time. May find themselves lost or turned around when not concentrating on a task, less precise in how they're parking. Social cognition, these changes in behaviors and attitudes, decreased interest and empathy in other people, or increased extroversion or introversion. I remember one time taking a group of students. I was teaching in Westminster at the time, and I was teaching a first year class, and we went to a long-term care community, and I only had like 2 or 3 men in my class. And this woman came up to one of my students. She took him by the hand and she gave him a kiss on the cheek, and she started leading him down to her room. She was a teacher in her work life, in her career. Her entire career was as I don't remember what level of teaching, but she taught K to 12, somewhere in there. And so obviously that's not the personality of a teacher, right? But this idea of, in this case, it was frontal temporal dementia. So these change in our behaviors, whether we become more extroverted, introverted, where we exhibit decreased inhibition, these can all be red flags that there's something serious happening within us. But I want to leave you with this, to just remember that age does not mean decline. Right? We weeks and months about, President Biden's age and ability, and former President Trump's age and ability. We need to get out of the idea that just because someone's old means that they're declining cognitively and mentally. It really, and we can't armchair and say, oh, that person's got bad judgment, therefore he's got cognitive decline because he's 78 years old, or that person is 81 years old and he's got dementia because, right? Age has nothing to do with it, right? It takes a true evaluation in order to determine whether someone has a cognitive decline of serious need. So I just want to leave you. This is Dr. Majid, and she will be your presenter next week. So we hope you can join us again. I know we've had over 500 people register for our series, the entire series, which is 7 events, 2 in-person conferences, and 5 webinars, beginning with this. And so we hope that if you registered, you enjoyed this presentation, and you'll be back with us next week to hear from Dr. Majid to learn the differences between reversible and irreversible causes of dementia, and dig a little bit more into some of the symptomology and the person-centered care that's so important that we're focused on, because oftentimes it's not the dementia, but how we treat the individual. So, that person-centeredness becomes so important when we're interacting with people that do have a dementia. Thank you. All right, I'm gonna look real quick in the Q&A and see if there's anything. We can put that. Someone asked about inflammation and gut health, and we can certainly add that. And when you do the program evaluation, if you can put some ideas of different topics that you would like to have us address, we'll see what we can weave into future webinars. And definitely, this is a series that we do want to have as an ongoing annual series, not just these 7 events. And there won't be 7 events on top of each other, but we definitely want to have additional webinars like this moving into the future. So when you complete that evaluation, it'll be one evaluation you get. It'll be the post-test with the same questions on the pre-test that you took, and then attached to that will be the actual webinar program evaluation. Let's see, Nicole says, so many of these do seem to be so similar to developmental disorders like attention deficit disorder. Are there studies associating the increase from ADRD? You know, that was something that even we speculated about way back, you know, in the 1980s and early 90s about some similarities between what we're seeing with ADHD and ADD. So I haven't looked at that literature, but Laura, could you make a note about that and see if maybe Dr. Majid can talk about that next week?
Yes.
Thank you. Same question. Okay. Everybody's got that question. So yeah, that's an important one, Laura. So let's see if we can have Dr. Majid address that. Does crystallized memory improve over time in major depression? With depression itself, no, you're not going to see, you know, you're going to see some true distress, and even that crystallized memory that making those connections becomes impaired as a result of the depression as well. My mother wants to leave every function every time early due to her hearing and being frustrated because she cannot hear. So I'm wondering if that would be a sign of it may just be a sign of overstimulation. You know, again, overstimulation, I'm not thinking about, you know, what she's being asked to do, but the noise. Think about holidays, Thanksgiving, and the whole family's there. I remember my grandmother, she would be in the living room by herself, and we would go in and talk to her, right? Because there was just too much commotion going on in the kitchen and in other parts of the house. So that doesn't necessarily mean a dementia. You know, there's a lot more to it, Beth, that you would need to look at there. Danita's question, Laura, right here. Someone diagnosed as a child with an executive function disorder more likely to develop a dementia. I think that's another good question for Dr. Majid next week.
Okay.
Is she also covering the role of genetics?
I'll ask her to.
Thank you.
I would think so.
Yeah, that's what I was thinking. Also, pure, you know, pure Alzheimer's disease under the age of 65 usually has genetic factors. There's, I think, 4 chromosomes now that we've made the link to, and then over the age of 65, and really when we get into our 80s and beyond, it's more of a mixed dementia that can be, you know, vascular and Alzheimer's disease and others that come together. Alcohol, there's actually a very specific type of dementia also related to alcohol abuse. Alcohol is another interesting one. You know, is it in moderation? Is it abuse? But there is Korsakoff's dementia is with alcohol abuse. And the interesting thing about Korsakoff syndrome, the alcohol, is I said before that procedural memory, our memory of how to do things, doesn't change as a normal part of the aging process. It also doesn't change as a result of having a dementia, except with Korsakoff's dementia. And so the occipital lobes in the back of your head, that's where your visual processing is done. And I can put that, Laura, can you spell Korsakoff's in the chat box for someone, please? That's the only dementia that we've recognized change in procedural memory. So something with that alcohol is doing something to those occipital lobes, and procedural memory changes. No, mild decline does not always progress to major decline. Yes, Twyla, we can certainly share. And like I said, this is going to be an on-demand series, and all of that will be available this summer. So it would be the transcript, the video, the booklet, everything would be available. But certainly we can see about making this information available to you. Okay, I'll pull back up that slide on depression versus dementia again, Sandy. Will the yes, all the in-person events are also being recorded. Do antidepressants or depression symptom management strategies lessen the impact on brain health? Yes. This is another good one, Laura. I was wondering, for the people that compartmentalize as a mechanism, will that be a reason to not consider dementia? So, and we have all these questions are being captured, so we can go through them and see what Dr. Majid would be able to answer, and then we can look to see where we might be able to weave some others in. Thinking this might actually be a really good question for our speaker on May 10th for one of the in-person conferences as well. Oh, good question. Are primary care providers mostly well-versed in evaluating dementia, or should someone be referred to a neurologist? No. Yes, referrals to a neurologist. Primary care physicians are not well-versed. They don't have time to do those differential diagnoses. And if you've gone to the physician's office, most PCP, primary care physicians now have boxes that have you know, you can, you're concerned your child has attention deficit disorder, and he reaches into that file box and pulls out something that you can do a self-assessment. If you look through that box, there aren't any self-assessments in there for geriatric depression screening or to do a cognitive assessment. So referrals to a neurologist or psychiatrist, a geriatric psychiatrist who specializes in dementia or Alzheimer's disease. But we're also, again, on the May 10th in-person conference, we're going to give you some tools to do some non-clinical assessments that can raise some red flags that would also help you to open up those conversations with your physician. One of the problems we have here in Maryland and really across the country is there just are not enough. Laura, what is the wait list now, like 3 months to get an evaluation?
Yes, I met a woman that she had to wait 3 months and without many resources or anyone that she could contact to ask questions.
So we'll give you some non-clinical tools in May. And yes, early dementia as early as 42 years old. Can you explain that? That would be a pure Alzheimer's disease, genetic. And again, there are 4 chromosomal markers for early onset. I think the most famous case was that basketball coach, I forget what school down in the South she had, and she was diagnosed with early onset. And Laura, do you remember? I think she lived like 6 or 7 years. But it was a pure Alzheimer's disease.
Yes.
All right, that's everything in the Q&A. I'm seeing questions about next week. Check-in again is 12:30. The webinar will start at 1 o'clock. We do have, like you see here, we have, well, we had about 260 was a high number that I had seen. We actually have about 400 people registered for our webinars, and it takes our team a long time to get through checking everybody in because so many people also want CEUs. So we really do have to make sure that everybody's checked in and checked out for the CEUs. Thank you. Yes, it was Tennessee. So we appreciate your patience. So 12:30 is the usual check-in time. The program begins promptly at 1 o'clock. If you don't need CEUs, you can come a little bit closer to 1 o'clock, but really if you need CEUs because of the size of the audience, we really do need you to be here early so that we can get you checked in. And did people appreciate the book? Should we repeat the book? Is that a good inclusion? Yes, okay. Great. Great. All right. All right, Laura, do you have some closing remarks?
Let me see. I'll put my video on. Hi. Everyone, thank you so much. This has been so great and interesting, and we love your questions. And that's why we need 5 webinars and 2 in-person conferences to really address all the intricacies and nuances that neurocognitive disorders present. So I just want to remind you that, yes, you can check in at 12:30 next week. The other thing was something that I should have written down. I did write down.
That's okay, you find it. Somebody asked
Yeah.
about CEUs. Yes, my team will begin compiling these on Monday. We have the templates all created. So we'll get the list on Monday. Min is here. She and her team of Sabrina and I think Justine's been helping to check people in with CEUs. Those CEUs, again, we've got a lot that are going out in busy schedules. We will try to get those out by Tuesday, Wednesday, no later than Tuesday, Wednesday next week.
Yeah. So there are 2 things. All the in-person conferences will be recorded, so we will have those materials available and to share with you. There will be a program book for that as well. And make sure that you realize that if you haven't had a chance to complete the post survey, it will be emailed out. So we're trying to collect enough data to see what difference the educational series really makes. So that's really important. So if you don't have a chance to complete it today, it will be sent in an email at a later date.
And again, it's the evaluation of the series as well. So, talking about if I was any good or not, things like that, as well as that knowledge assessment and attitude assessment. And also, please give us your ideas for future webinars, because we want to use that information to continue building this program. Oh, yes, Sandy, she's asking again. I will pull up that slide for you real quick. It's in here someplace. There you go. All right, Laura, did you drop or Min, did someone drop the evaluation link into the chat box a couple of times so people, you've got about 15 minutes. We wanted to make sure to build in time that you could complete the survey before our 3 p.m. end time. So you have about 15 minutes if I'm looking at my clock correctly. Yeah, now you're down to 10 minutes. So please
Yes, it's been posted in the chat box.
Perfect. And what do you want them to do? People who need CEUs, I see a lot of people are posting in the box about CEUs. Do you need people to stay on just to do a checkout?
Yes, please. I've been going through the list and I know some others. So if you are getting CEUs, if you could stay on, because we're going through the attendee list and making sure you're still there. We're also checking the chat.
Okay. And again, we are, I'm going to take this down. I can send it to you. There's a specific slide if you didn't get a picture of it. But we are authorized for CEUs for Maryland social work, Maryland psychologists, Maryland mental health professionals, all national certified senior advisors, and dementia care practitioners nationally. So those are the 5 CEUs that we're able to offer through our programs, but everyone will get a certificate of attendance. You all have a program book with speaker bios and content and learning objectives. You can take that, send that to your license. I know someone from West Virginia emailed me about it. If you take that to your licensing board, just send pictures or whatever, and they can check it to make sure that it meets their criteria. The only one we can't do, and I did see a lot of nurses on here, so we are looking for partners for nursing. So right now we can't give CEs for nursing. We are working on that, but if anyone has a hospital they work with and they'd like to partner with us to be able to offer CEUs, I know one of the guidelines for that is that a nurse does need to be on the planning committee. So it's very costly to do nursing, and we don't get a lot of requests for nursing, but we're happy to do it if we have a partner.